At this point, we have assessed all of the posterior pelvic counterstrain points bilaterally for tenderness, and we noted it in our patient. It was a piriformis point that was the hottest or the most tender point, and it was on the patient's right side. The patient stated that on a pain scale of 0 to 10, the pain was a 4 out of 10 in that piriformis location. And so we will now recalibrate or recalculate that 4 out of 10 to be equal to a 10 out of 10. And this is to help with our 2/3 reduction in pain that we're looking to achieve with the positioning of the patient. The first thing we're going to do is we're going to locate that piriformis point on the right side. So we work our way down to find that ILA on the right side. And then we will find the greater trochanter. Coming right in between the two is our piriformis point, and it is in the belly of the piriformis muscle. I will monitor this point for tenderness throughout the entire, I will just be monitoring the point throughout the entire positioning of the patient. Next thing I will do is I will be bringing the leg into the appropriate position, which is flexion at the hip, external rotation of the hip, and abduction. So I will use my right hand to bring the patient's leg off of the table and rest it gently on my knee or on my thigh. And I will scoot up, bringing that hip into flexion 90 to 135 degrees as needed. Again, I will be placing the patient into external rotation and abduction as well. And to do that, I can just shift my weight on the stool to induce that external rotation and abduction. And now I'm in the appropriate positioning for the technique. At this point, I will ask the patient, what is their pain now?
0.
The patient has stated that it is a 0 out of 10 in that location. So we will be monitoring this point and holding this position for 90 seconds. During this time, I can talk a little bit about the principles of counterstrain. Counterstrain is a passive and indirect technique. Indirect in the sense that we are bringing the patient into a position of ease away from the restriction, and passive in the sense that the patient is not doing any effort on their part. Once the 90 seconds has elapsed, we will bring the patient slowly and passively out of this position. And so taking care to just move very slowly, we will shift our weight back to bring that position, that position of flexion, bring it back into a neutral position, and then take the patient out of that external rotation and abduction. And we'll bring the patient's leg slowly up onto the table. And we will retest the tender point at this point. So what is your pain now on a scale of 0 to 10?
0.
And the patient stated that it is a 0 out of 10 now.